Welcome everyone to our last webinar Wednesday for the Health Management and Informatics Department at UCF. We're super happy you're here. There's going to be a few more that end up joining us as we go along, and also live on our YouTube right now, anyone there asking questions. So the typical way that we run our webinars is we do the presentations and we have all of our participants put their questions in the chat function. At the end, we do a question and answer Q&A session, and we'll address any questions that come up throughout the session there. So please utilize that chat function and send us your questions, okay? We are going to go ahead and get started today. First things first, our panelists, we do have Meredith Robertson, Daniel Stevens, and Ellen Trumpeter. They're all specialists in the different areas we're going to cover today. So today's kind of a group session talking about the different ways that healthcare integrates with law and public policy and kind of brings us all together here at the College of Community Innovation and Education, because we are in the Health Management Informatics departments, the Public Administration department, and of course Legal Studies. The first up, I'm going to be your moderator today. I'll be on the background taking care of your questions on the back end if you have something that you want to ask, and also monitoring the chat. And anyone on the live that's watching, you also have the ability to send us a chat question that we can do at the end. But first things first, I'm going to go ahead and pass it off to Ms. Meredith Robertson. Meredith, whenever you're ready.
Hi there, I am Meredith Robertson, and just to give you a little bit about my background, so I teach in the Health Management Informatics program. I teach managed care, health insurance, and community health. And to give you a little bit about my background so you'll know why I'm going to talk about the things I am today, I spent more than 10 years at the Centers for Medicare and Medicaid Services. And if you don't know what that is and you want to go into healthcare, you should write it down, because CMS really drives a lot of what healthcare is about in the United States. I also worked implementing the Affordable Care Act, which my claim to fame is I've actually read the entire law, which is crazy. Good hobby, or help you sleep, I don't know. And so I did that and helped a health insurance company implement it, which was a pretty big project. And now I'm happy to be at UCF teaching my classes. All right, we can go on to Katie. So I thought we'd start with a very broad overview, and so we can think about all of the different stakeholders. And when I think of stakeholders in U.S. healthcare, it might be a little different than most people because I come from a very policy background. So obviously, patients are going to be a big part of it, and providers. But remember, patients are also consumers. And so when I come from a health insurance background, I think about those of us who are buying health insurance. All right, we also have trade associations and lobbyists, and they are really going to drive a lot of the law and regulation that we're going to be talking about today. We also have the states. The states have a very unique relationship with the federal government, and we'll talk about that. Health insurance companies, researchers, and employers. And so employers, sorry about that. What are the odds of that? Anyhow, the employers are really important, and they're growing in their importance in the health insurance industry. So we'll talk about those things. Okay, Katie, if you want to go to the next slide, please. So I love this particular graphic. I don't know if you've ever seen it, but a member of Congress had his staff create this. And it was an outline of all the changes happening to the U.S. government as a result of the Affordable Care Act. So it's a little insane, frankly, to see all of these connections. And so two of the biggest pieces of legislation that I think are important to discuss is first the Social Security Act, which is amended in 1965 to create Medicare and Medicaid, and then a few years later created the Children's Health Insurance Program. And then the Affordable Care Act, as I've hit a couple times, the important pieces of that I think we should know about are, one, the employer mandate, which says all large employers have to provide health insurance. And then there's a lot of huge changes to the health insurance industry. One of them, of course, is pre-existing conditions. A health insurance company can no longer deny you health insurance. And they created the state health insurance marketplaces, also called the state health insurance exchanges. And they expanded Medicaid eligibility. And we will talk about those things in the next slide. So when you think about how we get into the nitty-gritty of law and regulation, first we have the law passes, and then the different government agencies have to interpret what that law means and create regulations or federal rules. And so the Federal Register is where you would go to read those rules, and that is published every day, every weekday. And so first they will create a draft rule that goes out there and is open to public comment. And a lot of people don't realize that you or I could write a comment to the government on any regulation that's out there. And the government actually has to respond to each and every comment. Now, what they'll usually do is they'll usually group them together. So if we all had the same comment, they'll respond to all of us in one paragraph. But they actually respond to all those comments in the next stage of the rules, which is the interim rule, or they could go directly to the final rule. So why is that important to all of us in healthcare? Well, it's important because things like the Medicare payment rates are actually published every year. So changes to how you are going to be paid in the hospital industry, those are going to be really important. So it's important to watch those different regulations that are coming out. There are different types of documents that are published in the Federal Register. So those include the regulations, but also presidential proclamations or executive orders, and documents that the laws require that agencies have to publish. I also want to mention that trade associations and lobbyists play a very big role in public comment. And so, for example, there's a trade association that represents all health insurance companies. And so the health insurance companies get together and they create their comments. And so that obviously has a lot more weight to it than if I submitted a comment on my own as an individual. So that's going to be really important, and that influences how regulations are written. There's also two different categories if you were to go to the Federal Register site. The first is public inspection, and that means that they're showing us what's going to be published on the next day. And then the next day, they have significant documents, which are those that are published. All right, next slide, please. So I like to just give a quick government insurance overview. So you could get health insurance through your employer, and a lot of Americans do. And it goes back in history to a law called the Stabilization Act. And this was during the time of the war, one of the World War II, and where we've had our different salaries were frozen. And as a result of that, employers only had health insurance to use as a recruitment tool. They couldn't hire somebody and say, I'm going to increase your wage from where you're coming from. And so as a result of the Stabilization Act, we had employment as a direct connection to having health insurance in the United States. And so that is why the United States is so different, one of the reasons, than other countries, is because health insurance is tied to employment. So what do you do if you're not employed? Well, you hopefully will be eligible for a government health insurance program. So those would be programs like Medicare, Medicaid, and the Children's Health Insurance Program. And if you don't qualify for those, then you can buy it on your own. Historically, health insurance has been very expensive to buy. Or if you had a pre-existing condition, you wouldn't be able to buy it. So those things have changed. And so let me just highlight for you the differences between Medicare and Medicaid. And I tell my students, you're not going to graduate from this program without knowing those two programs if I can help it. And so I talk a lot about these two programs. So to be eligible for Medicare, this is going to be people who are over 65 or disabled. For Medicaid, these are going to be low-income people. And so there are two major differences besides eligibility for this programs. The first is Medicare is paid for by all of us. If you look at your paychecks, you're going to see that there is a donation given to the government on every paycheck. Not a donation, that was a joke. But anyhow, so we all pay into it. And so as a result, we are all eligible for Medicare when we turn 65. Now, those federal funds then go into the program, and that means that no matter where you live in the United States, you would be eligible for Medicare at 65. Medicaid is different, Okay, so Medicaid varies by state. The states run their Medicaid programs. And that means that your income level is going to qualify you for eligibility in one state, but not in another. So you could be eligible for Medicaid in New York and move to Florida and lose your eligibility. So that is a very important difference. With Medicare, it's going to be the same state to state. Medicaid is going to vary. And similarly, the funding for for Medicare is federal, and the funding for Medicaid is paid for by states and the federal government. So those are the key differences there. All right, Katie, you want to forward to the next slide? So the state laws. So states obviously have their own variances in healthcare, from topics such as medical malpractice, which we're going to hear about shortly, the oversight of transportation and issues like that we'll also hear about in a few minutes. And there's other areas that are going to be important to you. One of them is that states protect us consumers from fraud. So if you know of fraud, you want to hit your state with your complaints because they are there to serve you. Providers are getting their licensing as well as insurance agents through the state. We also have the state regulators making sure that our health insurance companies are solvent. In other words, making sure that they're not going to go bankrupt if we all got sick on the same day. And so that's going to be important to protecting us, the consumer. And obviously, as I mentioned, eligibility for programs will be varied by state. And then also, the big role of state government and state laws is dispersing funds. So the state will receive money from the federal government, and then it decides how to use that. So we receive COVID dollars, for example, and there's hospital funding, and then of course Medicaid and CHIP dollars, and those are all dispersed based on how the state decides. So the other thing that just gives you a sense of variation, when you look at a specific law, a lot of them vary by state. And so that's what keeps all of us policy people really busy, because to keep track of all of it is a big handful. So one of the issues I find most interesting right now is surprise medical bills. If you haven't heard about this topic, it's kind of upsetting to most people because it's when you go to a hospital and let's say you're going there in an ambulance. Do you know whether that hospital is in network? Is it included in your health insurance coverage? Well, you're unconscious, so you can't be aware of that decision. And in the past, your health insurance company could say that was an out-of-network hospital, so you're out of luck. They can't really do that anymore. And so states are getting more and more involved on preventing surprise hospital bills or surprise medical bills. And so that's what that map there is showing you. Next slide, please. So one of the things I also like to bring up for students is to let them know how many different options there are out there. When you think of healthcare or healthcare administration, don't just think about hospitals and provider offices. Think about places like the World Health Organization or working for the Peace Corps. Think about working for the federal government. So if you were interested in the federal government, the key website to know is usajobs.gov. That website will actually allow you to search by geographic area or by department or government agency that you want to work for, and different levels of employment as well. So for example, you might want to work for the Department of Health and Human Services. Another area that students don't know about is compliance and auditing. So there is a government organization called the Office of the Inspector General. And nearly every federal agency has one of these OIG offices. And so if you are a person who is detail oriented and you like making sure that people are following the rules, working for the Office of the Inspector General might be a great place to work. So think about places like that. I've also listed the General Accounting Office and the Office of Management and Budget. They're heavily involved in policy and oversight at a federal level. And then there's agencies like the Environmental Protection Agency. If you are interested in issues related to water and air quality, that might be somewhere that you'd like to work. If you are concerned with occupational health, there's the Occupational Safety and Health Administration, or OSHA. So there's lots of options out there. You could also work for the state, right? Every state has healthcare employees. Every sector of Healthcare also has a compliance department. So there are people that make sure that the hospital is following all the rules, because the hospital sure doesn't want to get sued. And so those are compliance people, and some of those people do not have a law degree. So don't feel shy. If you're really interested in that, you may not need to go to law school. So there are lots of different compliance jobs. Then there are public policy jobs. And so that's kind of what I did when I worked for CMS. And that's where you get to interpret laws and create regulations, determine positions. So I got to advise the administrator on, if you make this decision, this is how it's going to impact this group of states, for example. And it's setting a precedent, and we have to think through how that's going to impact. And of course, how is it going to impact the budget, right? Certainly, we care about that in the government sector. And if you're a great salesperson, then you might make a great lobbyist. If you're really great with working with people and you like talking to people, that's a really great job. And it doesn't necessarily have to be, I think sometimes lobbyists have a really negative connotation, but it could be positive. For example, maybe you really care about cancer issues and you would work for the American Cancer Society. They have lobbyists. So think about that too. And then there's also jobs in public health. And I think all of us are hearing a lot about those jobs and the importance these days. And one of the great resources I've found is the American Public Health Association Job Board. And so if you're interested in looking at public health jobs, you can check that out as well. And the APHA also has student memberships, so you might want to check that out. All right, next slide. So obviously my background is in health insurance. So I wanted to offer some ideas for jobs there. So we have a lot of jobs in health informatics in the health insurance companies. So you could look there. Obviously customer service, quality measurement is a huge area if you are interested in that. There's also some creative jobs. Perhaps you're more creative and you would like to be in benefit and product design. And marketing and sales, obviously, huge departments in health insurance companies as well. And if you're going into nursing, there are lots of jobs there as well. For example, in care coordination, those are usually nurses. All right, next slide, please. So I also want to mention, of course, the employers. And so now that many employers have to provide health insurance, they are also very concerned about the cost. Healthcare costs keep rising. And so if you look at this chart here that I've provided, you can see that the employer contribution is growing, but so is the employee portion. So healthcare is growing, but so is the amount you and I will pay out of pocket. And so employers are getting very creative now. They are banding together and coming up with different value strategies. So really thinking about, how do we get better quality care for less money? What are efficient ways of doing that? The other thing I find is really exciting right now is there's a lot more transparency. We have a lot of nonprofit organizations coming out to create pricing transparency and quality transparency. So there are now hospital report cards, which you can take a look at for our local hospitals. They're out there. You can also see the federal government is now requiring hospitals to actually put their prices on the website. This is a huge push and very exciting in terms of transparency. So I've mentioned there at least two examples for you. Leapfrog Group does those hospital report cards. And locally, we have the Florida Alliance for Healthcare Value, which UCF has worked with extensively, and they are really innovative and very well-known group, on the national level, but they are locally here in Florida. And then we all know with COVID, telemedicine is growing and employers are paying attention. And so I think you're going to see a lot more employers thinking about using telemedicine after COVID. All right, next slide, please.
That was actually the end of your section, Meredith. Thank you
Great.
so much for your time. We already have a couple of questions that'll be really great when we get to the Q&A. I'm going to go ahead and move along to Dr. Daniel Stevens. He is our representative from the Public Administration Department. Dr. Stevens, please go ahead.
Now, there we go. Sorry about that. Thank you very much, Katie. A little bit about me. Of course, I'm faculty at UCF. Yesterday was actually my 13th anniversary serving on MetroPlan Orlando, the areas of metropolitan planning organization. That's really my forte. Public administration is a pretty broad umbrella, but my specific niche field is urban planning, with an emphasis on active, that's human powered transportation, cycling, and that includes public transportation. So that's who I am. Let me go ahead, and I'm just going to jump right into this. Let's go ahead to the next slide, if I could, please, Katie. The United States is currently challenged by the emergence of the COVID-19 pandemic, and almost every function of government is working to support the effort to mitigate the damage it's causing. To those of us in the transportation field, we've known for some time how access to essential services impacts public health. Public scrutiny of the government's responses to COVID-19 has exposed and highlighted some of the ways access to essential services is inextricably linked to people's ability to live a healthy life. Next slide, please, Katie. Because the foundation of most, if not all, public agencies includes an element related to health, it stands to reason that a health and all policies framework should be applied in order to identify opportunities to improve policies and programs to reduce barriers for people to live full and happy lives. This report describes some ways transportation and public health are interrelated. As I speak, think to yourselves how the following groups of people might be affected by transportation: seniors, lower income residents, the disabled, children, and active commuters, like I said, like cyclists and pedestrians. Now, while each group has its unique challenges, they share a common thread in that they're all some way they're vulnerable while traveling. Of course, even those residents who do not fit neatly into one of those aforementioned categories can still be adversely affected by transportation, especially as it pertains to impact on public health. Unfortunately, due to our time constraints, I'm only going to be talking about those living on the lower rungs of the socioeconomic ladder, low-income travelers. Next slide, please, Katie. People prioritize essential trips to help them meet their most basic needs: food, medical care, travel to and from work or school. The harder it is to travel, the more likely people are to forego trips that are less essential, or they may tend to prolong the time between those trips. Of course, when people have to choose between working or going to a medical appointment, they might rationalize that they need that paycheck more than they do, need to deal with that infected toe, until, of course, the infection spreads and becomes a bigger issue, right? Time spent traveling may increase substantially for people who take transit or travel via a shared human services transportation provider. The time-related burdens tend to be disproportionately borne by those with lower incomes. For instance, though commute times vary widely by region, in general, low-income workers have been found to spend more time commuting. 8% of workers, matter of fact, Katie, can you show the next slide? 8% of workers hold more than one job, meaning they may not control their hours, or they may have work schedules that conflict when transit is most frequent. Next slide, please. Exacerbating this is the fact that low-income people are also much more likely to be unpaid caregivers for a family member. More than 1 in 6 working Americans provide some unpaid caregiving, and the less money a person earns, the more likely they are to be a caregiver, spending on average about 24 hours a week. Next slide, please, Katie. Here in Central Florida, many people work in the service industry, right, out at the major theme parks, and they rely on Lynx, which is the Tri-County bus service. However, the service area of Lynx covers approximately 2,500 square miles, which is nearly 2.5 times more land area served by transit agencies of comparable communities across the nation. So that basically translates to a longer than usual transit time. Next slide, please. There are a number of reasons why enabling equitable and widespread access to essential services, such as healthcare, is a challenging problem. Problems resulting from existing infrastructure and built environmental constraints usually top that list, though funding prioritization methodologies and a lack of dedicated funding sources for transit carriers are certainly an issue. To put things in perspective, Lynx has an operating budget of around $150 million for fiscal year 2020, which equates to about the cost of improving a single interchange on I-4. That's a shame, right? Another significant challenge for transit operators is that the American Disabilities Act, the ADA, requires carriers to offer paratransit service, but federal transportation policy prioritizes the funding of capital expenditures over costs associated with maintenance and operations. So in practice, this means transit agencies are spending an ever-increasing proportion of their operating budget on service. Next slide, please. Of course, cost on a personal level is also a major factor, in that it influences each of these challenges and brings inequities into the problem. The Bureau of Transportation Statistics reported in 2018 that transportation is the second largest cost in the average American family's budget, largely because of the cost of car ownership. For those with low income, the high cost of car ownership means less money is available for housing, food, healthcare, other things that improve health and quality of life. At the same time, many low-income workers pay to own or operate a vehicle simply because they lack available jobs within a reasonable walking, biking, or transit commute time. Next slide, please. So, the sprawling land use patterns by which we've developed for decades are now haunting us. Over time, several factors have continually pushed lower income people further from transit accessible and walkable in-town neighborhoods. For instance, in recent years, cities have become more desirable locations for those in the middle and upper classes. Subsequently, housing prices have risen faster than incomes. Hence, people living in poverty have increasingly moved further from the urban centers into places that have cheaper rents. Furthermore, people who live in rural areas are disproportionately poorer and older than those in the cities and have longer travel times to services. So the trade-off for that migratory trend is usually fewer transportation options and social services. Now we find our nation has a large proportion of people who do not or cannot drive, living in places where transportation options are usually slower, less convenient, or more expensive, even if they exist at all. In closing, the following represents a short list of recommendations that span all levels of the public sector. These recommendations focus on pragmatic changes to policy or regulations that agencies and public authorities can handle administratively without passing new legislation. This includes more widespread adoption and implementation of a health in all policies type approach for transportation. So Katie, next slide, please. At the federal level, I begin with the U.S. Department of Transportation. The U.S. DOT needs to adopt a health in all policies framework to identify areas of opportunity within its existing policy goals to better integrate health supporting approaches. Reducing transportation barriers with a transportation network that has safe and convenient walking, biking, and transit options will have long-term health, economic, and environmental benefits. And while transportation might be thought out of the purview of the U.S. Department of Agriculture, the agency should continue its work to scale up delivering curbside pickup eligibility in every state. The USDA and its state partners have an opportunity to reduce barriers to health by making its food benefit easier for use in delivery. The SNAP food benefit is one of the most valuable social safety net programs for food insecure and low income Americans. The USDA should work with other state agencies to ensure that all state permit eligible SNAP recipients can use their benefits to purchase food online and have it delivered or available at curbside pickup. Smart, right? The USDA should also expand the program to include WIC and other subsidized programs. Another slide, Katie. States have administrative control over several existing federal reimbursement programs that could fund the cost of food delivery for the most vulnerable populations. These include the Home Delivered Nutrition Service Program for frail, homebound, or isolated older adults and people with disabilities, funded by the Health and Human Services Administration for Community Living. Another source is the Social Services Block Grant Program, administered by Health and Human Services Office of Community Services. That's a non-competitive formula grant that offers flexible funding to states and territories to create social service programs that best fit the needs of their populations. And it has an explicit goal of helping people who need support in order to continue living in their homes. At the regional or local level, stakeholders should apply a health and all policy lens across planning, transportation, and economic development departments. Most land use decisions are made at the local level, and plans and development codes that allow mixed uses in neighborhoods and prioritize walking, biking, or transit access would benefit all residents who could then potentially meet their daily needs without the necessity of a car. Woo-hoo, that's me. Local agencies could also expand access to food with a food hub program. It's something like it sells fresh produce at publicly owned assets such as schools, libraries, fire stations, and transit stops. Moreover, they could combine human services transportation with grocery delivery, leveraging existing vehicle capacity and providing operating expenses. Anyway, those are just a few of the areas where those of us working in public service can positively impact public health by enacting some minor changes within the policies, right? Thanks for listening, and don't forget to wear your mask.
Thank you so much, Dr. Stevens. I've got some great questions for you at the end as well. Thank you for covering that. We'll go ahead and move into the legal side of things. Ms. Ellen Trumpter is going to go over some medical malpractice and how the healthcare industry is impacted by the legal team. So Ellen, please take it away.
Yes, thank you so much. So I am currently a personal injury defense attorney. I have about 5 years experience. For about 4 of those years, I worked doing medical malpractice from the defense standpoint, defending all types of clients from doctors to hospitals. Currently, my practice has transitioned and I'm more focusing on the defense side of premises liability. I attended UCF as an undergraduate student and I graduated in 2012. So I'm thrilled tonight to come back and speak with you guys about medical malpractice. Currently, I am scheduled to teach a course of medical malpractice in spring 2021 on UCF's downtown campus. So here's to hoping everything kind of continues to go as planned. Okay, next slide. So clearly, medical errors are actually the third leading cause of death in the United States. So it is certainly a topic worthy of discussion. It is behind cancer and heart disease. Next slide. So an important question to ask at the very outset is, well, what is medical malpractice? So medical malpractice occurs when a healthcare professional provides negligent care that is below the standard of care, ultimately causing injury to a patient. So how do you know what the standard of care is? Well, you have to look to the statute, and as was already pointed out tonight, every state generally has a different definition. So in Florida, the standard of care is defined as the level of care, skill, and treatment, which is recognized as acceptable and appropriate by reasonably similar healthcare providers. So this means that we are essentially analyzing a healthcare provider's conduct and determining whether a provider with similar education, experience, and knowledge would have acted the same way in similar circumstances. So next slide. So what are the very clear examples of medical malpractice? Amputating on the wrong limb, operating on the wrong limb, failure to diagnose something, a misdiagnosis of something, misreading or ignoring lab results, and improper medication or dosages. So from an ethical standpoint, it's also important to consider what's not malpractice. So an undesired result is not necessarily considered to be malpractice. This can be hard for people to understand, and from an ethical standpoint, it can result in outcomes that just don't seem fair. Certain treatments have risk, certain surgeries have risks, and these should be explained to you, obviously, in full by your medical provider prior to undergoing any type of procedure. Certain surgical procedures often include the risk of death. And even if the surgeon does do everything correctly in the procedure, a patient may not survive. If reasonable skill was exercised, but the outcome was not desired, that does not necessarily equate to negligence. Liability will only ensue when a provider did not employ reasonable knowledge and skill. So for example, let's say you're in a car accident and you shattered your shoulder. So prior to the operation to repair your fracture, Your physician will tell you that the damage to your shoulder is extensive, and even if everything goes right in your surgery, you will likely have permanent nerve damage, range of motion difficulties, and mobility issues. So following the surgery, you never regain full range of motion and you experience a shooting pain that travels from your shoulder down your arm. There's no evidence that any mistake was actually made during your surgery. So under this very simple example, it's unlikely that the issues you continue to experience would be the result of direct medical malpractice. However, if you change the facts slightly, let's say it's determined that the shooting pain is actually due to a very small instrument that has been left inside of your body after the surgery, then that is probably going to be considered malpractice. So next slide. So another issue that comes up in this arena is the idea of medical malpractice insurance, but for physicians. So as you can see from the chart provided, malpractice insurance is costly for physicians. And because of that, some states actually don't require that physicians carry malpractice insurance, and Florida is one of them. So from an ethical standpoint, that certainly raises questions as to whether a society should allow this, especially when we look at the fact that medical errors is the third leading cause of death in the United States. So other than costs, why would a physician not want to obtain malpractice insurance? Well, some physicians think that it can reduce being the target of a medical malpractice claim. So this is because if a judgment is entered against a physician and the physician does not have the assets to recover the damages, the injured patient is left without a remedy, and ultimately they may not ever pursue the claim in the first place. So it can be risky pursuing a medical malpractice claim when the physician doesn't have insurance in the first place. In Florida, if the physician does not carry insurance, they are required to show that they can pay a judgment up to $250,000. However, medical bills are expensive, and an injury, future care, lost wages, pain and suffering could easily exceed the $250,000 pretty quickly. Next slide. So there's also ethical issues that actually rise on the other side when a physician does have insurance. So this usually centers on settlement. So there can be a conflict of interest created between the insurance company's attorney, and the healthcare provider. And Florida does allow an insurance company to settle a claim without the consent of a physician. This raises issues because a settlement can actually be a mark on a provider's record. It can be a matter of public record. You can go to the Department of Health and look up a doctor and see that a settlement has been made in a medical malpractice claim. So from an ethical standpoint, should insurance companies be allowed to settle claims without the physician's consent when the physician is the one that's actually paying the premiums for this insurance? Next slide. The next issue that is actually a major issue is statutory caps. And what that is a maximum award that a plaintiff can receive in a medical malpractice claim. So some states have caps on the entire amount recoverable, including past medical expenses, future medical expenses, pain and suffering, everything. Other jurisdictions they've only created caps on the pain and suffering aspect, the non-economic damages. Those are subjective losses, like pain and suffering, mental anguish, disfigurement, scarring, things of that nature. So ethically, are caps a good thing? Well, on one hand, it does prevent a company from going completely bankrupt over one large verdict. And in certain cases, these verdicts can be very large. But on the other hand, it can also prevent an injured person from being completely compensated for an injury. So for example, a 75-year-old who suffers from a medical malpractice claim may not really see as much damage to them with a cap on non-economic damages versus a 2-year-old who suffers an injury from medical malpractice with caps is certainly not going to be able to receive the same type of future care, but they will be treated the same and compensated similarly. So Florida actually does have statutory caps written into the statute. However, these were actually ruled unconstitutional in 2017. Next slide, please. So there are also ethical dilemmas that arise with respect to the statute of limitations, which basically means the timeline, the time period in which you can bring a suit. So in Florida, a medical malpractice action must be commenced within 2 years from the date of incident, or within 2 years when the incident should have been discovered. Florida also has a statute of repose that kind of operates in conjunction with the statute of limitations, and it prevents a cause of action from ever accruing when the injury is sustained or discovered after the statutory period has passed. And in Florida, that is 4 years. So there's some issues with fraud. Fraud grants a little bit of an extension, but I'm not getting into that tonight. With the statute of repose, there is an exception actually with respect to a minor child. The 4 years is extended up to the child's 8th birthday. So as an aside, in personal injury in the field that I more deal with on a regular basis, the statute of limitations to bring a suit for personal injury is 4 years. So it's a little bit different in the personal injury standpoint versus medical malpractice. Next slide. So now that we have a little bit better understanding of the statute of limitations and what a statute of repose is, let's talk about some of the ethical issues that can arise with these types of time limits. So the first issue is obviously, how can you measure what a person should have discovered? That's a very vague and kind of broad standard. So this is a very simplistic example, but for example, let's say a patient undergoes testing for prostate cancer and is advised that all the results came back normal. The patient continues to observe signs and symptoms that he knows are consistent with prostate cancer, but refuses to follow up or seek a second opinion. So 5 years later, additional testing shows that yes, indeed, he has prostate cancer, and unfortunately at this point, the cancer has spread. Under this scenario, the medical malpractice claim could be barred in the state of Florida. The patient knowingly had continued signs and symptoms with prostate cancer and should have followed up, which would have probably led to the discovery or of the missed/delayed diagnosis. So even though malpractice may have occurred, this patient waited too long and would not have a remedy in malpractice. Next slide, please. So while the statute of repose extends a claim for a child up to the 8th birthday, it actually operates alongside the statute of limitations. So it kind of creates an extra layer of complication. So this means that if a parent knew or should have known of a claim before the child's 8th birthday, the claim could still be barred. So after, and now this is another simplistic example. So after a complicated birth, baby A develops difficulty moving her arm. She has obvious weakness with her right arm and trouble gripping objects as her development progresses. Because the issues were obvious shortly after birth, baby A's parents probably would not have until her 8th birthday to bring a claim related to these injuries. However, if we change the facts slightly, if it was later discovered that baby A suffered a brain injury during the complicated delivery that was not discovered until baby A was 5, the parents could still bring a medical malpractice claim. Though it's important to note, they would have to still do so within the 2-year time frame. So they would not necessarily have all the way up until baby A's 8th birthday to bring this suit. Next slide, please. So why have time limits? And the scales of justice are here to provide balance. There's a theory that it is intended to provide physicians a right of finality regarding potential claims against them, but also allowing a patient a right to sue for any potential damages. The harsh reality is that there are some patients who are victims of utter malpractice who ultimately have no remedy in malpractice. And the ethical question remains, is that fair? So just as a final note, while they may not have a remedy in malpractice, they could have a remedy under other legal avenues. However, the damages would likely be much more limited than a malpractice setting, and probably wouldn't include issues related to the non-economic damages. Okay, last slide. So in conclusion, an undesired result does not necessarily lead to malpractice. A rise in premiums for malpractice insurance have caused some doctors not to carry insurance, and it has also inspired some jurisdictions to create those statutory caps on recovery in the malpractice arena. Most jurisdictions have strict procedures and limitations on bringing suit for malpractice. So if a patient suspects malpractice, they should definitely consult an attorney to not lose a possible remedy. Thank you guys so much for your time tonight. I appreciate having the opportunity to speak with you guys about these issues.
Thank you, Ellen, for sharing with us all of that info. It was definitely great. So now we're going to go ahead and move into the Q&A session. We already have a couple of questions in line. As we're discussing and presenting them to the panelists, please feel free to use the chat to insert your questions. So we're going to start and kind of rewind back to Ms. Meredith Robertson. We've got two questions for you. One, are Medicare reimbursement rates standard across the United States or up to the discretion of the states? And two, what are these reimbursement rates dependent upon to determine the rates for the year?
All right, those are good, very technical questions. So I'll try not to get too technical. So I love to say it's both. So are the fees standardized across the US? Yes, they are standardized, but they vary by geographic area. So a fee schedule is a complete listing of all the fees that Medicare uses to pay providers or doctors. And that fee schedule, they have different ones. So there's a fee schedule for physicians, for ambulance services, clinical lab services, orthotics, durable medical equipment, and then they're adjusted by zip code. And so what's interesting is that the Centers for Medicare and Medicaid Services, who oversees Medicare, they determine what's called a final relative value unit for every medical code. And then they multiply it by a conversion factor, a dollar amount, to get a national average fee. And then they're adjusted by geographic areas. And I just mentioned the relative value unit, not to try to get people confused, but because it's an interesting calculation, it includes covering the doctor's work, their practice expense, and their medical malpractice, their insurance. So that kind of ties it in nicely to our speaker, Ellen. So, so basically, yes, they're standardized, but they do vary by geography. So yes, they would vary by state. I hope that answers the question.
Thank you. Yes, it does. Awesome. So next for Dr. Stevens, earlier you mentioned the sprawl. Can you give us a quick definition of urban sprawl and what that means for the transportation?
Urban sprawl, can you hear me okay? I think I unmuted everything I'm supposed to here. Yeah, urban sprawl basically means that people live further and further away from the urban core. If you lived out in, let's say, Phoenix, Arizona, you know, the sprawl is not necessarily a big problem there unless it's codified, you know, because you go out, you can't go out in the middle of the desert and survive on your own because of water constraints, right? Here in Central Florida, you know, it's beautiful. You know, you've got plenty of land. You don't have mountains, you know, to constrain you. You have plenty of water. You have plenty of everything else. So you find that people just live further and further away from the city. And what happens is when people live out farther away from the urban core, that means we have to extend, you know, public services, you know, policemen, fire. You have utilities, cell phone towers, you know, you name it, sanitary sewer, potable water. And so that's the problem, is that when people live farther away from the city, it just costs a lot more. And as I hope I pointed out in my presentation, everything is a day trip. Everything, especially rule of thumb is that the further away from the city you go, the cheaper the land is. Right? You know, you're right downtown Orlando, it's going to cost you an arm and a leg. You live out in the middle of Bislow or something like that, it's a lot cheaper. However, that means that everything that you do, you know, is an hour-long trip. And if you're people on, you know, your low-income family, then that means that everything that you do costs money, or for transportation, costs time and money. So that's the problem with urban sprawl. Does that answer your question there, Katie?
Yeah, it does. Thank you very much. And for Ellen, so thinking on the medical malpractice side of things, kind of a twofold question. The first one being, with the proposed changes to the healthcare system, how do you think that'll impact medical malpractice suits, et cetera? And also, what do you think the impact of COVID-19 and the treatments and the possibilities that lie within the medical malpractice that might occur there?
I don't necessarily see medical malpractice changing or slowing with respect to any changes that may come with respect to especially insurance. And I think is interesting, the more that people don't have insurance, truly sometimes their only remedy is to kind of seek legal recourse for any injury that they may have sustained, because they don't have a way to pay for their medical expenses. And so sometimes that's just kind of the reality of an unfortunate situation. With COVID-19, I think the biggest issue that we're seeing, especially litigation, has just, it's completely changed. The past 6 months have been kind of a whirlwind, where we've gone from being everything had to be kind of face-to-face to really discovering that actually everything can be done virtually. However, trials are not going forward at this point in time. And I think from an injured person perspective, that has to be difficult to know that you're not necessarily getting your day in court. And because of all of the types of litigation, medical malpractice is incredibly emotional from both a physician standpoint and certainly from the injured patient standpoint. And both people tend to feel very, very passionate about their case. So you don't see a ton of resolution all of the time. And so I think there's going to be kind of a delay of people getting remedies. Hopefully, maybe people can come to more resolution, but I have not really seen that has been happening, at least in the area that I work in. So with respect to medical malpractice, I'm not sure that people will end up resolving simply because the court system's delayed.
Thank you. One more follow-up from Meredith. What do you think are going to be some of the top policy questions that come about because of COVID-19?
Well, that's really interesting. Well, I think we're still going to have a lot of privacy issues, I would expect, will come out of this. You know, we have HIPAA, which is a major law that we follow, but I think there'll be some unique things that come out. Telemedicine obviously is going to redefine what you know, employers and Medicare and Medicaid want to cover. So I think that's going to be interesting, especially when it comes to behavioral health. And I personally hope that we're going to see more access, particularly in behavioral health, because we have a lot of problems right now with getting people access. But with virtual, that could help. So I think that answered your question, yeah.
Yeah, thank you so much. So we're just gonna, these are the sources from a lot of the information that was presented today from our panelists. I want to thank our panelists for joining us and for giving us this great information. Seeing how healthcare is impacted by more than just a health administration field, but kind of spans across all of them and can be touched on in every aspect, and how it's impacting us today with COVID-19 is really important. You can always contact us and follow us on social media, the site's here, and we'll get you in contact with any of our panelists so that you can follow up information there. Again, thank you, Meredith and Dr. Stevens and Ellen. You guys were so great. Your information was awesome. All of this will be on our YouTube channel for access later to get more information. But other than that, thank you all and have a great day.
And thank you, Katie, for setting this all up.
For sure.
Thank
Bye
you
all.
so much.
Bye-bye, y'all.
Thank you.